Hello everybody, we are now moving on to the thoracic wall, the lungs and the pleura. Here are the objectives for you. You can pause this and study it on your own, or you can of course refer to the PowerPoint that should be uploaded in your learning management system. Surface anatomy-wise, there are a couple of landmarks that we can actually identify. You have your jugular notch, the clavicle, you have the anterior axillary fold, you have the manubrium and the sternum. The sternal angle, aka the angle of Louis, is an important landmark, usually between the T4-5 IB disc. You can see the ribs, especially in lean individuals. Here's your xiphoid process in the xiphisternal joint. The margin below the rib cage is called the costal margin. Remember, costa means ribs. And there's the mid-clavicular line, which is a line that intersects the clavicle in the midline. You will have within the trunk or the thorax, of course, your heart vessels and the heart, the lungs and trachea, thymus. Well, not really in adults, the thymus will be gone. It'll just be a little bit of like fatty tissue, but in infants and small children, you still have a thymus, esophagus, nerves, and lymphatics. So what is the thorax actually good for, or the thoracic cage? Well, in general, we could say it helps or provides a protection of the internal organs, and well, the shape of a cage helps resist the external and internal positive and negative pressures with lightweight skeletal structures, right? So it actually does provide the space, so compartment to house important organs like your lungs and your heart. It also provides an important attachment site, or actually attachment sites to be specific, for the muscles of respiration. That would be not just the diaphragm, but also the muscles of, or accessory muscles of respiration, the intercostal muscles, for instance. And of course, the thorax provides the attachment for the upper limb and the neck. So the walls of the thorax remain rigid, but yet movable. Yeah, we can actually increase the transverse diameter and the AP diameter of the thorax during inspiration, and of course we decrease those diameters during expiration. Yeah. Normal respiration just happens with the diaphragm. Expiration is just passive recoil of the diaphragm, but when you're like working out and running, then you also have secondary muscles that help with respiration. That means that you're actually your anterior, posterior, and transverse diameter of the thoracic cage gets bigger. Yeah, not just the diaphragm moving up and down. Here I'm including a picture from the dissector, so we're going to have to first, of course, skin the thorax as far as we have not done so yet, because we should be finished with the upper limb. And then we're going to reflect our pectoral muscles, which again we should have done bilaterally. If not, then make sure you do that we can then gain access to the thorax. You can see here some of the incision lines. You probably know by now from your experience in lab that dashed lines are lines that you actually should cut. Okay, so make sure you familiarize yourself with the dissection instructions. You're going to cut and reflect the pec major, if not done so yet, and the pec minor as well. Both of these should already be done. And then of course after that we're going to have to do some cutting of the ribs and also the clavicles. Let's have a look at different types of ribs now. Okay, the ribs in general are considered to be lightweight but highly resilient curved and flat bones. And the spongy interior of a rib will contain bone marrow, which does form blood cells, so it's hematopoietic tissue. And there are three types of ribs. There are true ribs that will attach directly to the sternum. Yeah, so this is a posterior view, so you can see the sternum. You have false ribs, which are ribs that join to the cartilage of the rib just superior to them. You can see some of it down here. These are false ribs. And then you have floating ribs, which are number 11 and 12. They do not connect to the sternum, and they don't connect to the ribs above them. 11 and 12 are just floating ribs. Okay. Thoracic apertures. We have a superior thoracic aperture. It's also called the thoracic inlet. That's just pretty small and transmits structures like your trachea, esophagus, the vagus nerves, and major blood vessels. The inferior thoracic aperture, which is down here, is bounded anteriorly by, or is bounded by structures of the inferior thorax and the diaphragm. It's obviously much, much bigger because the diaphragm goes all the way across there. And some large structures have to pass from the thorax to the abdomen, so of course there have to be openings for that, right? So that would be, for instance, your esophagus and your aorta, but also lymphatics like the thoracic duct have to pass through the inferior vena cava, maybe the vagus nerves as well. So several structures pass through, but in the terms of these smaller structures, they usually travel together with larger structures, like together with the aorta through the aortic hiatus, or with the esophagus through the esophageal hiatus, as it happens, for instance, for the vagus nerves. So right here, this is what we're going to be aiming for. Once we've cut the clavicles, we've removed the chest plate, we can look into the thorax, and then we want to be able to get access to the heart and the lungs. Let's have a look at some features of a typical rib. So ribs 3 to 9 are considered typical ribs. They do have a head with 2 articular facets. These facets are where they articulate with the vertebrae above and below. There's a transverse crest in between them. Then you have the neck. You have a tubercle on those ribs, at least, that articulate with the transverse processes. Yeah, it has smooth articular and rough non-articular parts. It has an angle, which I have put in here as a little blue box, because that is the weakest part of the rib. Or actually just anterior to that is the weakest part, and that's where you have fractures occur most frequently. You have a little groove here. This costal groove is the groove where your intercostal nerve, artery, and vein travel. And the rest of the rib here is the body. So now let's move on and have a look at some of the vertebrae. This is an example of T6 and T7. You can see they have half or demi-facets, right? These are important for the articulation with the heads of the ribs, okay? Then you have costal facets on the transverse processes, like you can see here and here. Those are for the articulation with the tubercles of the ribs. And in the thoracic region, you have long and slender, slanting spinous processes. So, for instance, you would have the head of rib T7 articulate with the superior costal facet of vertebra T7, that's the superior costal facet, and with the inferior facet of T6. If we have a look at the joints of the head of the rib, there are only slight gliding movements possible here, yeah, and the costotransverse joints, which will allow a little bit of rotation between ribs 1 and 7, and more gliding between 8 and 10. The reason why we have a little bit of motion that has to be possible at the joints of the heads of the rib and the costotransverse ribs is exactly that. Our thorax does provide a safe cage, basically, but it has to be able to expand and, well, reduce or get smaller a little bit when our lung capacity has to be maximized. We have more joints of the thoracic wall. We have joints called intervertebral joints, costovertebral, sternocostal, sternoclavicular, and manubriosternal and xiphisternal joints. You guys know the drill, so usually the name is the game in anatomy, and that's exactly what happens here. In addition, worth mentioning is that although movements of the joints of the thoracic wall are frequent, like for instance during respiration, the range of movement at the individual joints is really small. Any disturbance that reduces the mobility of these joints will interfere with respiration. Joints of the thoracic wall will be occurring between all the structures that are listed on this slide. You can also refer to the notes if you want some more detail. Here we have 2 views of the diaphragm. The diaphragm is our chief muscle of inspiration that'll separate also our thoracic and abdominal cavities. This view over here is a superior view, and the view down here is an inferior view. The diaphragm will be moving up and down like bellows that used to be used to fan a fire, for instance. And while you're breathing in really deeply, well, if your diaphragm moves down, it'll compress the abdominal viscera a little bit during inspiration. During expiration, your vertical diameter will return to a neutral position as there's some elastic recoil from the lungs that produces subatmospheric pressure in the pleural cavities between the lungs and the thoracic wall. So that means as a result of this, and also the absence of resistance to the previously compressed viscera, the dome of the diaphragm ascends and diminishes the vertical dimension. Now we're going to have a look at our diaphragmatic apertures, which are the mechanisms by which we provide a passage for structures like the esophagus, vessels, nerves, and lymphatics between your thorax and your abdomen. We have the inferior vena cava passing through an opening called the caval hiatus. The esophagus passes through the esophageal hiatus, and the aorta through the aortic hiatus. All of these have a certain vertebral level at which approximately they pass through, which would be 8, 10, and 12 in the thoracic region respectively. So the mnemonic that I use is I ate 10 eggs at 12. That means inferior vena cava at T8, at T10 the esophagus, and at T12 the aorta. On this image you can see the difference between the normal or resting breathing and inspiration that occurs if you have paralysis of the right hemidiaphragm over on the picture on the right over here. So usually you would have the diaphragm when you're breathing in move downwards, as you can see here, because that helps make the space in here bigger. You can also see that you do have the rib cage getting a little bit wider, and then when you breathe out, this whole thing reverses. However, if you have, well, half of your diaphragm paralyzed because you have a lesion to the phrenic nerve on one or the other sides, remember C3, C4, C5 keeps the diaphragm alive, you might have something that ends up looking like this, and the telltale sign is this paralyzed hemidiaphragm, where you can see on the right side during inspiration the diaphragm is actually arching upwards, and on the left side it does what it should, it pulls down. You can see a little bit of air density here in the stomach. There's the outline of the heart, your clavicles, here are the spinous processes of your vertebrae, just to point a few things out. So this is what a hemidiaphragm looks like on a radiograph. So the primary movement is for the diaphragm to increase in vertical dimension, right? So you see expiration and inspiration. During inspiration it pulls down, it increases the vertical dimension. You also have forced inspiration and forced expiration, which will either widen or narrow the thorax respectively. And so we also have different movements that we can superimpose on there. And this movement is called the pump handle movement, like an old-fashioned water pump. As you can see, you have an increase of the AP, or anterior posterior diameter. You can see here's the axis of movement going right across here. And so you see we do have a slight increase of the AP diameter. In addition to that, there's also a bucket handle movement, very fitting because there's a water pump, so there needs to be something to pump it into. That is a bucket handle. That is the elevation and depression of the ribs, and that will help increase the transverse dimension of your thoracic cage. The muscles of your thoracic wall, we can have a look at them here. Your muscles of inspiration, the principal muscle we all know now is your diaphragm. The dome will descend, increasing the vertical dimension of the thoracic cavity, and elevate the ribs. There's the diaphragm, and there it pulls down, increases the vertical dimension. You have 3 layers of intercostal muscles. The external intercostals will elevate the ribs, increasing with the thoracic cavity. You have the interchondral part of the internal intercostals, who also elevate the ribs. You have accessory muscles of respiration, which would be, in this case, your sternocleidomastoid, this large muscle, that helps elevate the sternum. And you have these muscles, the scalenes. You have an anterior, middle, and posterior scalene. The anterior scalene is an important landmark for the identification of the phrenic nerve. They will elevate and fix the upper ribs. Muscles of expiration, quiet breathing, is just the passive elastic recoil of the lungs in the rib cage, and the tonus of your abs. And during active breathing, you have your internal intercostals, except for the interchondral part, that will help depress the ribs. Then you have the transversus thoracis. This is that depresses the lower ribs and compresses the abdominal contents, so it'll help push up the diaphragms, right? Transversus thoracis is actually on the inside of the rib cage. The six-pack muscle is the rectus abdominis here. Then you have your external oblique, internal oblique, while the transversus thoracis is on the inside of the rib cage. All of these will help with active breathing. Here comes another important slide, because this is something from your dissector. We are going to look at the different layers of intercostal muscles, okay? Note that you have a certain order of the intercostal neurovasculature, which would be VAN, V-A-N, or vein, artery, nerve, okay? These three layers of intercostals, if you look at the external intercostals, it's a superficial layer, yeah? The orientation is infero-anterior, like putting your hands in your pocket, okay? During forced expiration, they will elevate the ribs. Then you have the next layer, which is, well, you see the fiber direction is perpendicular to that. That means it is the middle layer, and the orientation of the fibers is infero-posterior. It depresses the ribs with forced inspiration. And then you have the innermost intercostal muscles that will also help with the forced expiration. Okay, please do note that in the costal groove is where you're going to find your intercostal vein, artery, and nerve in exactly that order. That's important to realize because, well, when you give an injection to anesthetize the intercostal space, you need to be careful that you actually don't hit any of the structures. This is pretty well protected by the rib and the costal groove. However, you have collaterals as well that are traveling right about here. You don't want to damage either the nerve, artery, or the vein. If we have a look at some more of the arteries and veins of the thorax, usually you have arteries and veins that have like similar or the same name. When the thorax is not quite so. Well, having a look here, we have first our aorta, of course. That's clear, that's the parent vessel of just about everything in our body. The first or the highest intercostal artery is called the supreme intercostal artery. Then you have a whole bunch of intercostal arteries basically for every rib space that supply the rib space, and that together with collateral intercostal arteries. So we have arteries supplying above and below the rib respectively. Same thing is going to be with the veins, no big difference, that's all fine. And then you have on the inside here an artery which is called the internal mammary artery or the internal thoracic artery that travels left and right of the sternum inferiorly. Yeah. You also have the last artery that comes off here below rib 12 is called the subcostal artery. Again, this name makes a lot of sense because it's below the rib, so subcostal. And after the internal thoracic artery ends, somewhere down here, it becomes the superior epigastric artery. And there's another branch which might not be shown. I know it is shown here. That is the musculophrenic artery. Okay, so the internal thoracic artery travels all the way down here, and then it splits into the musculophrenic artery that supplies some branches to the diaphragm as well, and the superior epigastric artery. Okay, vein-wise, you have these intercostal veins. So you have a supreme intercostal vein, you have superior intercostal vein, and on the vertebrae themselves, you have the azygous vein and the posterior intercostal veins traveling along there. Traveling through the diaphragm from inferiorly is going to be your inferior vena cava, which enters the heart into the right atrium. A couple of things about the azygous and hemiazygous system of veins. You can see them traveling along here. That is your azygous vein that then with the arch of the azygous vein goes into the superior vena cava. And well, why do we have this? Well, it kind of acts as a collateral pathway between the superior and the inferior vena cava. It will also drain blood from the posterior walls of your thorax and your abdomen. And the azygous vein, as I just said, will join your SVC or superior vena cava. The accessory hemiazygous vein will usually descend on the left side of T5 to T8 and then crosses to join the azygous vein. Let's have a look at our little intercostal neurovasculature here. Here especially we will look at the intercostal nerves. All the spinal nerves will contain sympathetic fibers, at least within the thorax, because we're between T1 and L2. Well, in the thorax, we're just in the thoracic region, of course. And so you actually have your gray and white rami communicans, right? So these sympathetic fibers are important because they will go to blood vessels, to sweat glands, and to smooth muscle of the body wall and the limbs. Remember here, for every dermatome, which is the patch of skin supplied with one pair of spinal nerves. You also have a so-called myotome coming from the anterior horns of the gray matter, going through the anterior rootlets, anterior roots, the mixed spinal nerve, and then going to, which is called the myotome, which is the patch of muscle corresponding to the dermatome above it. Clinical applications. Herpes zoster or shingles usually occur unilaterally within one dermatome, and the reason for this is because the varicella virus will lie dormant within the dorsal root ganglia, aka spinal ganglia, of a specific spinal segment. Okay, so here's a little drawing of like what it can look like. This is the characteristic dermatomal appearance of these herpes zoster outbreak. And as I said earlier, I just hinted at it, when you're anesthetizing intercostal space, it's important to know the arrangement of the neurovascular bundle so that you can do your nerve block safely and easily for procedures, for instance, like as placing a chest tube. Rib fractures, I might have mentioned that earlier. The weakest part of the rib is just around the anterior part of its angle. Okay, middle ribs are the most frequently fractured ones, as you can see here. You have simple fractures, which would be, for instance, a transverse or oblique or an overriding rib fracture. You could also have a chondral fracture, that's actually over here, or a costochondral separation, which is the separation between the bony and the cartilaginous part of the ribs. More complicated are these fractures over here, like for instance, if they also traumatize the pleura and the lung, that can lead to air or blood in the lung. That would be a pneumothorax for air and a hemothorax for blood. You can have multiple rib fractures that can damage the pleura underlying, or of course you could have a compound fracture by a missile. This would be, for instance, a bullet or something, or a puncture wound. Okay, danger, especially in this region here, is that the heart is very close to the surface anteriorly, so you could damage the heart or other great vessels, so the ascending or descending aorta, etc. The thoracic cavity itself is divided into 3 compartments and will contain the 2 pulmonary cavities with the lungs and the pleura, and the area that stands in the middle. Here it is outlined kind of in a reddish shade, numbered 9-ish. That is called the mediastinum. Yeah, that's exactly in the middle, that contains all of the other important structures. So the lungs are surrounded by a serous pleural sac called pleura that'll consist of 2 continuous membranes. Okay, there's visceral pleura, also called pulmonary pleura, that will cover the surface of the lungs, and it adheres to the surface of the lungs all over, including the surfaces within the horizontal and oblique fissures. Okay, it cannot be dissected from the lungs, just like the pia mater on the brain and spinal cord. Then you also have the parietal pleura, which lines the pleural cavity, so the inside of the thorax and the mediastinum and the diaphragm. This parietal pleura is named depending on where you find it. Now you, for instance, have the cervical pleura, where the cupula is, which extends above the first rib. That's important to know, actually. If the superior limit of the lungs is above the first rib, that's already where you can injure it. So if you have injuries to the superior thoracic outlet, it can easily create damage to your lungs. Okay, down here, these points, or these places down here, these recesses, are called the costodiaphragmatic recesses because it's the recess between the diaphragm and the ribs. That's the deepest part, basically, that you can get to. So that's also where you're going to have a collection of blood or fluid that can be drained right out of the costodiaphragmatic recesses. The lung has surface projections. Okay, specifically you have the parietal pleura, and the anterior border of the left lung will deviate from the midline a little bit because they will circumvent the area where the heart lies. This is also called the bare area. That's where the pericardial sac will be accessible, for instance, with a needle, with much less risk for injuring the pleural cavities or the lungs. if we look at this superior view now, at the bare area, the pericardium is going to be in contact with the anterior wall. See, here's the bare area, so you'd be able to access the pericardial sac directly without injuring the lungs at all. This dashed line that is outlining these two right and left regions is the outline and the extent of the parietal pleura. So the recesses that you have down here are the costodiaphragmatic recesses, and these recesses up here are the costomediastinal recesses. So there's this procedure called a pericardicocentesis, where if you have blood extravasating into the pericardium, you can imagine that it'll cause something called it can cause something called a tamponade, which can be lethal if not treated. So then you would actually be able to insert a wide bore needle through the left fifth or sixth intercostal space near the sternum, or via the infrasternal angle. So you can either approach it here, or here, or here, and like that you would be able to aspirate the fluid out of the pericardium and possibly save someone's life who is in grave danger of dying of a cardiac tamponade. Next in line is the pulmonary collapse. The lungs, or more specifically the air sacs that are collectively making up the lungs, are comparable to an inflated balloon, for instance, right? That is when they're distended. If the distension is not maintained, well, as they are elastic inherently, just like a balloon, they will collapse. That is called atelectasis. Secondary atelectasis at the collapse of a previously inflated lung, and primary atelectasis is refers to the failure of a lung to inflate at birth, as it happens in newborn infants. An inflated balloon remains distended only as long as its outlet is closed, because its walls are free to fully contract. So if you have a sufficient amount of air that enters the pleural cavity, as in this image right here, well, the surface tension that would occur between the lungs and the visceral pleura of the lungs and the parietal pleura around here is not going to be enough. There's usually a very thin layer of fluid between the visceral pleura and the parietal pleura, but if we have air that comes in here, we break this surface tension between the two layers of pleura adhering to each other, and the lung will collapse because of its inherent built-in elasticity. When it collapses, you would actually have the pleural cavity, which is usually a potential space. It becomes a real space. Luckily, the pulmonary cavities are completely separated, so if one lung collapses, you still have another lung to keep you alive. Not very well, but it does keep you alive because the pleural sacs are completely separated from each other. Now we can have a look at the root of the lung and the hilum. So the roots of the lungs are technically, well, the attachment sites of the lungs to the mediastinum, as you can see outlined here in these dashed blue circles or ovals. Okay, they consist of all the structures that will enter or exit the lungs at the hilum. The hilum is kind of the doorway. That will be, for instance, the bronchi and the pulmonary neurovasculature. Here is the hilum dashed in the dashed yellow oval here. That's kind of more like wedge-shaped area on the mediastinal surface of each lung, through which these structures that form the roots of the lungs will pass through to enter or exit the lung respectively. On the right and left sides, or the right and left lungs, the order of structures is slightly different. If we look at the right hilum and the left hilum, you can see that the pulmonary arteries are anterior on the right lung and superior on the left lung. In lab, unfortunately, nothing is color-coded. However, you can tell the difference between the main stem bronchus and arteries and veins, because the main stem bronchus is very cartilaginous, whereas the veins and arteries are not. They're much thinner. Other than that, you really do have to go by location here. It is hard to tell which is an artery or a vein, especially if your dissection might have gone a little bit too deep. So pay attention when you remove the lungs, they don't cut too far into the tissue of the lungs itself before you remove them. A cadaveric image is a little more like this here. You can see the right hilum Here's the pulmonary artery in front, and the left hilum with the pulmonary artery on top. The course of the phrenic nerves is going to be anterior to the root of the lung, in both cases, on the right and on the left lung, and the vagus nerve is always going to be going posterior to the roots of the lungs. The trachea is only so long, it'll actually bifurcate at the level of the sternal angle, aka the angle of Louis, into the left and right mainstem bronchi, as you can see here as well. There's the sternal angle. Here is the right mainstem bronchus. On the other side is the left mainstem bronchus. You can see that the right mainstem bronchus is wider, shorter, and runs a little bit more vertical than the left mainstem bronchus as it passes directly to the hilum of the lung. Well, that is the reason why if we have a foreign object lodged, like aspirated into the lungs, it most likely will lodge in that right mainstem bronchus, as you can see here. This is one of these little things that you pop into your shelf to hold the shelf up, or into your bookshelf. This ended up getting inhaled by a very small child, it seems. You can see that these joints, or actually the joints have not completely finished growing up here. There's a lot of cartilage, there's some epiphyseal plates here. Everything looks much, much smaller, and the inside, the heart looks enormous compared to the rest of the thorax. So this is a small child, I would say, and you can see lodged here in the right mainstem bronchus is this little thing that holds a shelf up when you buy one at IKEA or something like that. Next we have so-called bronchopulmonary segments. Bronchopulmonary segments are the largest subdivisions of a lobe of a lung. They are usually pyramidal-shaped segments of the lung, and their apices face the lung root and their bases at the pleural surface, separated from the adjacent segments by connective tissue and septa. They are supplied independently by a segmental bronchus and a tertiary branch of the pulmonary artery, named accordingly to segmental bronchi supplying them. They will be drained by intersegmental parts of the pulmonary veins that will line the connective tissue between them and drain the adjacent segments. Usually there are 18 to 20 in number. There are 10 in the right lung and 8 to 10 in the left lung, depending on the combining of segments. The important part about this is these are surgically resectable because each bronchopulmonary segment can be regarded as an independent unit. That's why we can remove it surgically without affecting the function of the other segments. If we look at the internal structure of the lungs, we can see a couple of interesting things. So within the lungs, the bronchi and pulmonary arteries are paired, and they also branch in unison. Tertiary segmental, they're also called tertiary branches, supply the bronchopulmonary segments. Each intrasegmental pulmonary artery, which will be carrying poorly oxygenated blood, ends in a capillary plexus in the walls of the alveolar sacs and alveoli, where oxygen and carbon dioxide are exchanged. The intersegmental pulmonary veins will arise from the pulmonary capillaries and carry the well-oxygenated blood back to the heart. Bronchial arteries are distributed all along and supply the bronchial tree. The most distal branches will supply capillary beds that are drained by the pulmonary veins, such as those of the visceral pleura. A very small amount of low oxygen blood thus drains into otherwise oxygen-rich blood, which is conveyed by the pulmonary veins. New alveoli will continue to develop until about the age of 8 years, by which time there are quite a few of them, which is approximately 300 million alveoli. Some clinical considerations. Pulmonary embolisms. Pulmonary embolisms are, for instance, the blockage in one of the pulmonary arteries in your lungs. In most cases, pulmonary embolism is caused by a blood clot that will travel to the lungs from your legs or rarely from other parts of the body, like deep vein thromboses. Because the clots block the blood flow to the lungs, pulmonary embolism can be life-threatening. However, prompt treatment usually greatly reduces the risk of death. Taking measures to prevent blood clots in your legs will help protect you against a pulmonary embolism. There's also pleurisy. Pleurisy is an inflammation of the pleura called pleuritis. Pleurisy causes sharp chest pain, like pleuritic pain, that worsens during breathing. A variety of underlying conditions can cause this kind of pleurisy. Treatment of pleurisy involves pain control and treating the underlying condition. Some signs and symptoms of pleurisy may include chest pain that gets worse when you breathe, cough, or sneeze, shortness of breath, as you can imagine, because you're trying to minimize your breathing in and out. In some cases, there's a cough. In few cases, there's a fever, and pain caused by pleurisy may also affect your shoulders or back. Here's a picture of a pulmonary embolism. The blood clot that is formed in the leg travels upwards, and it is then inside the lung or a lung blood vessel, blocking the blood supply to the lung. Here we can see the pulmonary trunk, the superior vena cava, the ascending and descending aorta. And so a so-called saddle embolism can occur if you have a large clot that sits right at the bifurcation of the two pulmonary arteries, which is of course very bad news, because that means you might block all of the blood flow back to the lungs. So that is probably one of the most dangerous types of emboli there are. Pneumothorax. Here we can see two examples of pneumothorax. On the right side, over here, you can see that we actually have much more air density, and it is the only stuff that is actually absorbing X-rays is going to be the skin and subcutaneous tissue and the bones, because the pleura has collapsed here. You have atelectasis of all of this lung tissue on the right. You can see this even better here. This is a higher resolution X-ray. Your pneumothorax is all over in this region. You can see the collapsed pleura on the right side. So here your potential space has turned into a real space. So now you have a real pleural space, whereas it should only be, like it is on the left side here, a very, very thin line. You can also see here the branching pattern of your bronchi, possibly also some of the pulmonary vasculature, which is an indicator that the left lung is still fully inflated, whereas the right lung, we only have a little bit of it left, kind of more medially here, but here this is just an open, empty space. Now we can have a look at the sympathetic supply to the lungs. Remember that in the thorax we have, of course, our gray and white rami. We have going to the lungs specific splanchnic nerves called cardiopulmonary splanchnic nerves. So they will be postsynaptic fibers that will coming from the sympathetic trunks. Their function will be to be inhibitory to the smooth muscle of the bronchial tree. They are bronchodilators. They're stimulatory to the blood vessels of the lungs, so they're vasoconstrictors, and they will inhibit the alveolar glands of the bronchial tree. The parasympathetic supply of the lungs is from the vagus nerve, or vagus nerves, cranial nerve number 10. It will be motor supply to the smooth muscle of the bronchial tree, so bronchoconstrictors. It will be inhibitory to the pulmonary vessels, so it'll act as a vasodilator. And it will be secretomotor or secretory to the alveolar glands of the bronchial tree. There's more detailed information in the notes if you like, but quintessentially, this is the most important information. Thank you for your attention. Please do get in touch if you have further questions. Otherwise, we look forward to doing the dissection in lab with everyone.